Good evening, everybody. My name is Mary Burley, and I'm the Chief Educator here at the museum, and we are completely delighted to welcome you to what is our third Art, Love, and Identity 50th Anniversary Summer Lecture Series. And tonight we have the distinct pleasure of hearing from Dr. ERIK Plakun. ERIK is the medical director and CEO at Austen Riggs, where he's a member of the senior leadership group and the ERIKSON Institute Management Group. And his accolades go on and on. You've done an awful lot, ERIK. But a few highlights. He's the editor of New Perspectives on Narcissism from the American Psychiatric Press from 1990. Treatment Resistance and Patient Authority, the Austen Riggs Reader, 2011, and the author of close to 50 articles and book chapters on the diagnosis, treatment, longitudinal course, and outcome of patients with borderline personality disorder and treatment-resistant disorders. He's a Distinguished Life Fellow of the American Psychiatric Association and serves on the APA Board of Trustees representing New England and Eastern Canada. And before he started at Riggs 41 years ago, he was a general practitioner in Vermont. So not a totally straightforward course, but chose Riggs for the commitment to patient-centered care in a world that is not always making that possible. I think the other piece that is important, you can go online and read an awful lot about ERIK. In terms of our community, ERIK has also served on the zoning board of Stockbridge for 21 years, and he's one of the few people that you can expect to see every morning, or at least 6 days a week, at 6:30 in the morning on his bicycle on the streets of Stockbridge. So ERIK is a treasure in our community and for Austen Riggs, but also I think has demonstrated through his own service a broad understanding of community and how we can all take care of each other. So particularly at this moment in time where mental health is on all of our minds, and I think maybe it will come up in the questions, but we've had lots of issues locally recently. We're just so happy that you're here, ERIK.
Thank you, Mary. That's very kind. I really appreciate you all coming. I know it was for the air conditioning, not for the talk. But I have some pretty good PowerPoint slides. I enjoyed making them. And I hope to tell you this, a story that's really about 3 different stands that were taken that I think have mattered. Just so that I have a sense, how many people have involvement in the world of mental health, either as a practitioner or as a seeker of services, and so there's a good smattering of people who have, and how many people know something about law and or insurance? Well, everybody else. Okay, I kind of had a hunch. So great. Again, thanks for coming, and let me take you through this. I'm going to talk to you about what I've come to speak about as the 4 freedoms of mental health, and how they relate to some moments of standing for what matters. And here's a sort of an outline of what I'm going to try to talk about. First, I want to review the history of Franklin Roosevelt's 4 freedoms and Rockwell's images of them. And then I want to explore the question of, well, are these 4 freedoms still relevant, or are they some old thing from the 40s that we should relegate to the trash heap? And then I want to spend some time reviewing issues in access to mental health care in this country and take you to how I get to these 4 freedoms. So that's my plan. That's the roadmap, and we'll see how well I stay on course. So in January 1941, in his State of the Union, between the Great Depression and World War II, Franklin Roosevelt took a stand about democracy in his speech and spoke about the 4 freedoms: freedom of speech, freedom of worship, freedom from want, and freedom from fear. He actually included in that speech an interesting line that the benefits of democracy include the promise of adequate health care, but it was perhaps a little early for that to take lodge in America. The response to his speech was, as some have said, crickets. There was not a lot of interest in this concept of the four freedoms when it was first introduced. During the Second World War, about 1943, Norman Rockwell has some conversations about paintings related to the four freedoms, with the idea that these might be something that help to sell war bonds, and he does his four paintings while living in Arlington, Vermont. And they're over here. We'll talk about them a little bit more one at a time. And the response to his paintings when he brings them into the Pentagon is also kind of crickets. Not much interest, sort of deafening silence, until the Saturday Evening Post picks up the four images and puts them on the cover of the magazine and sort of features them in each of several issues. And this turns out to be a terrific marketing campaign. They get traction. They become an important part of selling war bonds. I apologize for the sound. I'm trying to be close enough so that you can hear me, but then I hear there's a sort of popping. If you're having trouble, let me know what I could do to help it. So Rockwell's images do wind up taking off and becoming important. And as you know, the originals live here. And what better place than Stockbridge, small town New England democracy, which is kind of what we're about. Occasionally, the last couple of years, that's been a little embarrassing if you read the Berkshire Eagle, but it's small town New England democracy. So one question is, are the four freedoms still relevant? Well, here's some of the evidence. I would say, if you pay any attention to the media on the national political scene, the question of what's happening to democratic values and inclusivity, whatever side of the issue you're on, it seems to be a pretty relevant issue in a continuing way. And it's interesting that New York State Governor Andrew Cuomo cited the four freedoms in his speech setting the 2019 legislative agenda. But beyond that, there's a very interesting little thing that happened. Smithsonian Magazine reconceived the Rockwell images for the 21st century. Have any of you seen that? Oh, okay. Well, okay, one person. Oh, okay. The usual suspect. Yes. So I'll take you through them and sort of give you a glimpse of what's changed. How are people thinking about this differently? So, for example, freedom of speech. It's the famous Rockwell painting of, the man in the leather jacket without a tie, standing up at town meeting in Arlington, Vermont, and speaking freely, while people, mostly men, everybody's white, looking up at him admiringly, and the others in the audience seem to be the bankers and the people with white shirts and ties. But actually, Rockwell said that the actual moment of this was this gentleman was getting up and saying why he did not think the school that had burned down should be rebuilt. So it was a minority view in the town, but it was American small town democracy, free speech. And so when the Smithsonian Magazine had an artist reconfigure it, this is what they came up with. For now, a woman of color, origami birds tweeting their way out of her mouth. One says #MeToo. I mean, yeah, time's up. There's quite a bit of political message in the refiguring. So it's an updated image, but it's the same basic value. Freedom from fear. The Rockwell image shows parents, presumably, looking at their sleeping children in an upstairs bedroom, and dad's holding a copy of a newspaper that talks about bombing in London and the Blitz, and this is in the pointing back to the the clouds of war that were gathering in Europe at that time. This is the reconfiguring that the Smithsonian produced. It's a couple in a detention center tucking their children in at night. It's off because the parents are with the children, and there seems to be a lot more room than one would imagine. But you can see through the door the guards outside and the barbed wire and the bars, this sort of thing. But this is the updated freedom from fear image that is the 21st century one. And then freedom from want. You know, this is one of my absolute favorites, that probably Thanksgiving feast because it's daylight and there's this huge turkey and all these people looking at each other, making merry, clowning, all white. And then the Smithsonian reconfigures it. And what we have is as many screens as people, what looks to be an entirely vegetarian meal. And I think there are no two people making eye contact. Everyone is either looking at their screen, or even the baby is looking at the screen. But you know, here we are in 21st century America. Freedom from want. Thou shalt have a screen. Freedom of worship. Actually, so this is the original that Rockwell painted. Again, interestingly, all white, but a very powerful kind of an image. And the one the Smithsonian offered is not very different, except it's far more diverse. More women, more people of color. You have to get back in the ranks. Let's see, 3 takes you to the Hasidic Jewish man, and 6 takes you to what presumably is a white Protestant male in this group of people representing a diverse portrait of America. So the same stories, the same 4 freedoms, all kind of updated. And my answer to the question of whether the 4 freedoms are still relevant is, well, if democracy is still relevant, so are the 4 freedoms. And the stand that Roosevelt took about, look, we need to hold these 4 freedoms in mind. And sure, it's not all of what democracy is about, but the notion that these are pillars and they're central and there's something that's a kind of a rallying cry related to these, that's important. So now to another stand. You know, the exhibit upstairs is about the relationship between Rockwell and ERIKSON. And actually, when Erikson came to Riggs in 1950, he was taking a stand. This was at the height of the McCarthy era. The House Un-American Activities Committee hearings pictured in the slide were going on. And under California law, professors like Erikson at the University of California at Berkeley were expected to sign a loyalty oath. He took a stand and said, I'm just not going to do that. He didn't make a big dramatic issue about it, but he just wasn't going to do it. And so he accepted this job offer that came his way from the Austen Riggs Center in Stockbridge. And that's actually how, in relation to taking that stand, Erikson winds up in Stockbridge. You with me so far? Okay. So now I want to shift a bit into the world of what's going on in the world of mental illness, mental health. You've probably heard about stigma. It makes its way into the news, into discussion. Stigma and mental illness, it has its roots in bias against those who are different and make us feel uncomfortable. I mean, if we go back to the Salem witch trials and earlier in history, this is about, you know, the notion that, well, mental illness is really demonic possession or it's witchcraft. It's an old, fearful idea. Actually, I think the real first origin story of the Austen Riggs Center is in the early 19th century when Philippe Pinel in France went into the lunatic asylum in Paris and said, you know, maybe we should treat these people as just people, and maybe they'll get better if we take them out of their shackles and sort of give them clothing and food and try to give them a social structure. Moral treatment. I actually think that's one of the first origin stories of Austen Riggs, but this isn't mostly about Riggs. Stigma relates to obstacles to providing or accessing care as well. You know, as hard as it is to get care on the medical surgical side of things, it can be even harder in the mental health side of things. And it even leads to lower reimbursement rates. A Milliman Corporation study compared what does a psychiatrist get paid for doing the same service compared to a primary care physician or internist, if it involves a prescribing of a psychoactive medication, for example. And the psychiatrist gets paid 20 to 70% less for the same service. This is why, I don't know if you are aware of this kind of thing, but many more psychiatrists than other physicians operate outside of the insurance system because, well, I mean, it's complicated. This is just one piece of it. But if the reimbursement is less, and you know, why be part of something that that's going to not allow you to do treatment in a way that you feel is appropriate? We'll get to that down the road. So this is about stigma. Now, you may have heard about the dangers of dehumanizing treatment as well. Anybody who saw that film, Ken Kesey's One Flew Over the Cuckoo's Nest, knows something about, you know, that kind of dehumanization that can be part of treating people. You know, dehumanization has to do with the unnecessary use of restrictions, seclusion, or restraint when providing treatment, rather than, like Pinnell, recognizing, oh, these are people, and they can rise to the occasion if you expect them to. And viewing a patient not as a person with a story, but as a diagnosis. You're my bipolar. Or viewing a person as simply a mouth to swallow pills or a receptor site for molecules. I think these are dehumanizing trends in treatment that are really not acceptable. You know, this is really not what the human brain looks like. Made of a bunch of red, white, yellow, blue, and green pills. Now, ERIKSON himself knew something about stigma and dehumanization in treatment. His word that he introduced was pseudo-speciation. Pseudo-speciation, I mean, it's such a mouthful, I don't think it's caught on, but you know, I introduce it, try to say that 3 times fast, but I'm going to say it slowly. But pseudo-speciation is the tendency of members of in-groups to consider members of out-groups to have evolved as if they're a separate genetic species. They're separate, they're distinct, they're just not me. They're something entirely different. ERIKSON first used this term in 1966, and dehumanization is one of the outcomes of pseudo-speciation, as are ethnic discrimination and genocide. And certainly, ERIKSON himself was coming to the U.S. from what was going on in Germany with the persecution of Jews, well, beyond Germany, throughout a good chunk of Europe by the time he got here. So freedom from stigma seems to me to be a foundation of mental health. Similarly, freedom from dehumanizing treatment is another foundation of mental health. There's the cover of the One Flew Over the Cuckoo's Nest. Great film. So I knew a nurse once who was reputed to be the actual Nurse Ratched. She didn't seem that bad to me. Now, take a step over to Riggs to explain this next part of the story. So Riggs is a U.S. News and World Report best hospital in psychiatry. You know, this small place on the main street of Stockbridge. We treat about 150 patients a year. Winds up there in the list along with places like Johns Hopkins and Mass General, places that are huge medical centers. We were a long-term psychoanalytic hospital for difficult-to-treat patients, the people who've tried other things and they haven't worked well enough. Yet it's got this completely open setting, you know, it's this moral treatment origin story that emphasizes patient dignity, patient freedom. We hold people not with locks and restriction, but with relationships, with agreements. It balances freedom with responsibility. With this freedom comes the responsibility to keep yourself safe and to be serious about pursuing treatment. And we're proudly celebrating our centennial this year. Founded in 1919, actually July 21st was the actual date. And we had a bit of a party, a 1919 themed party. Did you know that the dessert of 1919 that everyone wanted was peach melba? And I learned where peach melba got its name. You can ask me in the question and answer period if you're interested. So an interesting thing happened in the early 1990s. This was after the failure of the Bill and Hillary Clinton healthcare initiative. There was this effort to try to introduce national health insurance. It collapsed. And in the face of that, and in the face of escalating costs for all kinds of medical care, including psychiatric mental health care, I mean, it was double digit. It was 15% a year, and something had to be done. In response to that, managed care expanded. That is, insurance companies carefully reviewing each case and deciding whether they would approve treatment. And the insurance industry, through managed care, stopped covering longer-term treatment, the kind that we do at Riggs and that many people provide in outpatient treatment. And at that time, Riggs took a stand about mental health treatment. The stand was, treatment is about more than crisis stabilization. The insurance companies really only wanted to cover the stabilization of a crisis and then end treatment. And the position we took was that, look, we must treat the underlying problems to achieve true recovery. You have to go beyond crisis stabilization. And we took the following stand. Either the world will figure out that we're right, or we're probably going to close, because we're not going to become a short-term locked hospital, length of stay, a week or two. Well, about 2 years later, we had reached a full census. There was a long waiting list. And we were being imitated. But we did this operating outside the health insurance process because they simply were going to limit their treatment to crisis stabilization. Now I have to take a little detour here to talk about, well, what's the goal of, I'm sorry, I should have spelled it out the first time, MHSUD treatment. That's mental health, substance use disorder treatment. Such a mouthful that I just abbreviated that way. What's the goal of treatment for mental disorders and substance use disorders? Well, look, we know, it's fact, many patients struggle with chronic or recurrent disorders, probably most patients. There are some who have simple disorders that get better easily. Many have co-occurring disorders. We know, for example, that at Riggs, the average person who comes to us meets criteria for 6 different disorders at the same time. We know that early adverse experiences or recent trauma are very common in people struggling with mental disorders, and that early adversity and recent trauma are powerful predictors of a complicated course. We know that our treatments work, but we also test them on single disorder patients. That is, we pull out of all the depressed people the unicorns who have just depression. They're just not like the patients who come to psychiatrists' actual offices who also have an alcohol problem and maybe have an anxiety disorder and maybe have an eating disorder. And when you use these treatments on the people who have the co-occurring disorders, the treatments do not work as well. Given this reality, given that this is what we're up against in treating people with mental disorders, the goal of treatment is improvement in functional status to achieve this thing called recovery. Now, it's not my word. This is actually a word that's used widely in the field, and SAMHSA, the Substance Abuse and Mental Health Services Administration, defines recovery this way. They say that recovery is a process of change through which individuals improve their health and wellness and live a self-directed life. That's really the key part. Live a self-directed life and strive to reach their full potential. So that's what recovery is, and that's the goal of treatment. When we who are in the field train, we don't spend our time principally focused on, here's how you do crisis stabilization, now you're trained. We learn crisis stabilization, but we also learn how to move people toward recovery, treatment over time. And that's a different goal than the goal that has largely been used by insurance entities. And the image I have is of a pot boiling over, because I think that's the best analogy. The insurance companies, sadly, tend to respond to the pot boiling over of a mental disorder by taking off the lid, stirring it a few times, and then putting the lid back on. Well, you know that fairly soon the lid it's going to boil over again. What's not happening is turning down the flame. That's different from crisis intervention. So the focus of insurance companies has been crisis stabilization rather than recovery. By the way, it's interesting. Do you know why? I mean, I can't say that I know the answer, but it's an interesting thing that the average American changes jobs and insurance policies every 3 to 4 years. So the incentive that an insurance company actually has is to keep costs down for 3 to 4 years, not lifetime benefit. It's an interesting incentive that may well play some role in what happens. So the insurance industry has limited access to care to the current problem and then to reducing or ending services. Once the crisis is solved, you no longer need inpatient. Once you've had a few outpatient sessions, you're done. We're not paying for any more. Now, I'm not speaking about every single insurance company in every single instance, but I am talking for the broad majority, and you'll see where this takes us. But you can see the case I've been making is that we have to watch out for pursuing the wrong goal of treatment. The wrong goal of mental health treatment is crisis stabilization. The goal clinicians know and train to pursue is the goal of recovery. And I believe that the freedom to pursue recovery is a foundation of mental health. Now, I told you, are you with me so far? Okay. Yep. I told you that Riggs took a kind of a stand about this, and it did. I mean, Riggs just said, well, we're not doing this. I mean, you can't run a short-term locked inpatient unit on the main street of Stockbridge. It's not what we are, who we are, where we are. We're not doing it. But over time, it's not just Riggs. Riggs has been joined by many other clinicians and facilities that have come to say, wait a minute, this focus on crisis stabilization is off. There's more than crisis stabilization that has to happen if somebody's really going to live a self-directed life and achieve recovery. And gradually, through legislation and litigation, the nation has come to embrace the stand that we took. I want to give you some of the steps. 2008, Patrick Kennedy is influential in the passing of the Mental Health Parity and Addiction Equity Act. It's simply called the Mental Health Parity Law. Oops. And the law, the Mental Health Parity Law, says, look, if an insurance policy is going to cover mental health as well as medical services, then they have to be covered comparably. There can't be a substantial difference, and you can't set up more stringent access requirements or limits to care for mental health. In 2014, 6 years after the introduction of the parity law, the so-called final rules of the parity law were released, and they specify that parity applies not only to inpatient treatment, like for those of us in the county, Jones 2 or Jones 3 up in Pittsfield, at Berkshire Medical Center, and not only to outpatient treatment in a clinician's office, but also to intermediate levels of care like residential treatment, longer-term facilities like Riggs. It specifically says, wait a minute, you've got to cover at parity with medical services, residential services of the sort we offer at Riggs. So the parity law was an important step, as was the Affordable Care Act, Obamacare. It said that, look, by the way, part of the essential benefit packages of insurance has to include mental health services. You can't just leave those out. That was one of the solutions under the parity law. It was, if you cover mental health, then you must have parity. So we won't cover it. But the Affordable Care Act plans under the exchanges, that law said, well, you have to include mental health. It's an essential part of the benefit. It reinforces the parity law. The Affordable Care Act says there must be parity, and it did another very interesting thing. It required that insurance companies disclose their previously secret criteria for how they made the decisions about care. But that was the Affordable Care Act in 2011, but there's been minimal enforcement of the parity law. Parity law is 11 years ago, 2008. There's been minimal enforcement of the parity law, probably because the Obama administration needed to be friendly with the insurance industry to have the exchange plans get put together and launched. And under the Trump administration, you may have noticed that there's not a lot of support for the Affordable Care Act. It's repeal, replace, chip away at it any way you can. And then this year, another important step in completing the circle of moving in this direction of it's not about crisis stabilization, it's about recovery. Our neighbor Senator Chris Murphy, Democrat of Connecticut, introduced his Mental Health Parity Compliance Act. This is a bipartisan bill in the Senate and the House. It's co-sponsored by Republican Senator Bill Cassidy from Louisiana. There's a House version of the bill, also bipartisan, and it requires insurers to reveal and make public their compliance with the mental health parity law. As they say, sunlight is the best disinfectant. If an insurance company is required to say, this is how we're doing in parity, then when they try to sell that plan to IBM or to an individual, it's going to raise questions if they're not following the law. But it's still more complicated. These kinds of laws, this is about top-down solutions to the problem of access to care. And it's going quite slowly. So in addition to top-down, we need to think about bottom-up solutions. Bottom-up solutions begin at the grassroots, begin with the people who are covered or not so well covered by their insurance policies. And this has taken the form of class action lawsuits against large insurance companies based on their criteria for access to care. A recent example is called Witt versus United Behavioral Health. You may have heard about it. This was national news in March when the verdict came out. And after I have a swig of Diet Coke, I'm going to tell you just a little bit about this suit. So, health insurance contracts generally guarantee that in return for your premium, I mean, they don't all say the same thing, but this is the general thing that they say. In return for your premium, they will provide coverage for treatment that is, quote, medically necessary. So what is medically necessary? Well, according to the American Medical Association and the American Psychiatric Association, medically necessary treatment, I won't take you through all the fine print, is treatment that meets generally accepted standards. This business of generally accepted standards becomes key. So if you have pneumonia, the generally accepted standard is penicillin. It's not leeches. There are generally accepted standards, and those treatments are medically necessary. There are 4 sources of generally accepted standards. There's what's the research show? A very important component. But even in a field like cardiology, about half the recommendations are consensus among expert clinicians and not based on research. So it's what do the professional organizations say in their guidelines. In cardiology, actually only about 11% of the guidelines are solid research. The other is the best opinion we have. That's why you see things like last year it was good to take low-dose aspirin to prevent heart attacks. This year, not so good. It's what's the consensus we have on the bits of evidence we do have. It also involves practice patterns. What are clinicians actually doing? And then some other things like the Medicare manual. Medicare simply covers so many people that the rules of the Medicare manual become part of generally accepted standards. Now, look, before I go any further and come off as bashing insurance, it's probably too late to sound like I'm not. I really believe this, and I want this to be clear. Managed care operates with exactly the same moral imperative as the environmental movement. You know, there's a limit to how much greenhouse gas we can put into the atmosphere, how much CO2 we can put in. We have to manage scarce resources. We have to manage things. But we have to manage it in a way that's consistent with the generally accepted standards. And many people agree, for example, that climate science is kind of nailed. It's pretty clear. And we have to follow the same rules in providing medical or mental health care. It's sure we have to manage resources, but we have to follow the generally accepted standards, GAS. So here's what this lawsuit was about. It was, well, if health insurance contracts generally provide coverage for treatment that's consistent with generally accepted standards, if the company's using flawed standards to decide on treatment, is that a breach of contract? My contract says I'm going to get medically necessary treatment that meets generally accepted standards. Are you using the right standards? This is the claim that was made by plaintiffs in multiple class action lawsuits. Witt versus UBH Optum is the most important one because this is the nation's largest behavioral health insurer. More people covered by, it's the single largest. And there was a class action in which the plaintiffs claimed breach of contract in exactly this way, in people getting access to outpatient treatment, intensive outpatient treatment, more sessions, more groups and things like that, and residential treatment. As it turned out, they were looking for an expert in this case, and I was one of the people they wound up selecting to testify in this because there aren't that many people who are expert in all three of those levels of care, and I've been at Riggs for a long time. The trial took place, it took a year and a half for the judge to reach his 106-page verdict, but this was issued on March 5th. This is a class action suit in federal court in the 9th District in California, and here's the judge's, part of the judge's verdict. Having reviewed all the versions of the guidelines for all the years, the court finds by a preponderance of the evidence that in every version of the guidelines, at every level of care, there is an excessive emphasis on addressing acute symptoms and stabilizing crises while ignoring the effective treatment of members' underlying conditions. He goes on, in each version of the guidelines, the defect is pervasive and results in a significantly narrower scope of coverage than is consistent with generally accepted standards. Judge Spiro said, those of you who think the insurance industry, as manifest in this one large insurance company, has been using the wrong standards, you're right. That's his verdict. I won't take you through all of this, but he's basically, it goes on to say that, look, you've got to treat the underlying condition in addition to the crisis that somebody has. And the treatment should include attention to co-occurring disorders. I mean, so there's a whole list of things that he winds up saying that as you go down the line, support all the positions that the plaintiffs took. It's been called a landmark decision. This is the liability phase of the trial, and last month, the remedy phase of the trial occurred, and the verdict is will come out on that, which is how is United Behavioral Health going to fix this. They've already proposed adopting the measures we've asked them to use, but you know, this is not finished, and it will be appealed. But this is not the kind of case that seems likely to go to the Supreme Court, I'm told. I mean, I'm not a lawyer, but it's contract law. This is not new law. This is contracts. They're as old as the hills. And either there's been a breach or there hasn't. A really landmark kind of decision. So I would take from this that, you know, that what it teaches us is that freedom of access to medically necessary treatment is another foundation of mental health. And so I propose that we frame these four freedoms that I've kind of taken you through as the foundations of mental health. They aren't the only ones, but they seem to me to be the key ones that are relevant today as we face a world where we want to move forward in being able to treat people with mental health and substance use disorders. They're freedom from stigma, freedom from dehumanizing treatment, freedom to pursue recovery as opposed to just crisis stabilization, and freedom of access to medically necessary treatment. If you have insurance and it guarantees access to medically necessary treatment, you ought to be able to get it. We're actually at Riggs establishing a 4 Freedoms of Mental Health Award for advocacy. we've picked that little oak leaf with 4 F's on it for each of the 4 freedoms as a sort of a logo for it. And we're actually going to give the first awards this September at the centennial celebration we're having at the Lindy Center at Tanglewood on September 21st, and you may want to join us. You'll find out who's getting the awards. And this is actually, there's a handout with this, but we're that same weekend we're having an international conference celebrating our 100th anniversary, the mental health crisis in America, recognizing problems and working towards solutions. We have quite a range of speakers from current and past presidents of the American Psychiatric to leaders in psychoanalysis in this country and elsewhere. And Tom Insel, former head of the National Institute of Mental Health, Carol Gilligan, and Caroline Reynolds, who was the day-to-day attorney in the Witt versus United Behavioral Health case, who's going to tell us the story of that trial in that case. So, as they say, thank you for listening. I'm happy to try to answer any questions. Yeah, well, that makes 2 of us, and maybe about 40 of us. I mean, look, one answer, and this is, of course, the errand of the DSM, the Diagnostic and Statistical Manual of the American Psychiatric Association, is to define mental disorders as carefully as possible based on research and consensus, and to come up with the right categories. And, you know, generally speaking, there has to be some set of symptoms or experiences that are troubling and interfere with the ability to work and love, to work and to have relationships. Freud said, you know, well, what is mental health? Well, it's the ability to work and love. Many of us at Riggs like to add the ability to work, love, and be a citizen. Things that interfere with that are complicated. Now, you know, the effort with the DSM, one of the best-selling books of the last couple of decades, is to carefully define the categories so that we can do the research, do the brain imaging, and find out what exactly is the brain configuration of bipolar disorder, to do the genetics and find out just what exactly is the gene for schizophrenia. It's very interesting. When all is said and done, and we've done the best categories we can, and you do the studies of brain imaging, all the same parts of the brain are involved in all the disorders. And there's about 250 different genetic loci connected to schizophrenia, and about 40 with depression, and some of them overlap. There are no, it's not genes equal disease. What we've learned is that the old question of is it nature or nurture? The answer is yes. And of course now today's language would be, it's not genes equal disease. It's gene by environment interaction equals disease and health. So it's very complicated, and that's what we're learning. And so it's extraordinarily important that we have these categories because they allow us to test the hypotheses. And it doesn't look like the hypotheses that these are simply separate biological entities is a valid hypothesis. I hope that answers. Yeah, well, it's a very terrific question, and I love the way you posed it because it creates the answer in a certain sense. So look, in 1999, then director of the Human Genome Project, Francis Collins, now the head of the NIH, said, wait till we decode the human genome. We are going to see a revolution in healthcare. Diagnosis is going to become all about genes, and treatment's going to become all about the informed biological treatment. Wait till we break that genetic code. 2003 or 4, we decoded the human genome. And the promise has not been delivered except in a few areas. Oncology, cancer is one of them. Incredible progress. We're finding what's the gene vulnerability around this. This has been transformative, but in most of medicine, not so much. And when it comes to something like breast cancer, although there are, the genes that one wants to discover, you said it exactly. It's popular movement. It's a social movement. We can't let this happen to women and not spend money investing in research. And I think the same kind of thing needs to happen, but we have this problem of stigma. And this country is particularly prone to either or. So there was an era when psychoanalysts were promising too much, delivering too little, and then they got thrown into the trash heap, and the biological psychiatrists came along and they promised too much and delivered too little. It's very hard to move from either or to both and in treatment, but I think that the social movement quality is what's essential. And we have a really, well, it's what the conference is about, I think really quite a broken mental health system with so many people getting their treatment by being imprisoned. We let people out of the mental hospitals and they became the homeless. Or they became, they get arrested and they wind up in prison. The highest paid jobs for psychiatrists in the state of California are in the penal system. The largest mental institution in the nation is the LA County Jail. So as a society, we have work to do about creating the kind of social movement, and that's part of why I've tried to talk about the 4 freedoms, that I think these are the kinds of freedoms that people can identify with, that people should be free of stigma. They should be free of dehumanizing treatment. If the real goal of treatment is recovery, they ought to be able to pursue that rather than just have their crisis stabilized and then it boils over again in 3 months, and they ought to have access to care. But so I think it's, there's social policy issues and what's popular and what's not. And there are the ways that promise about what would happen, we have to rethink it. There's some interesting, what are we going to do about the, Tom Insel, former head of the NIMH, has been quoted to say, look, as head of the NIMH, I spent $20 billion trying to move the needle on mental health care by studying the brain. And although we learned a great deal, we didn't move the needle on outcomes one bit. That's from the former head of the NIMH. He then says, and I went to Silicon Valley where I tried to use big data to approach the problem of mental health. And he said, mental health is not going to come from an app. And what he talks about is the importance of community. And that's what we try to stand for, community as a way of approaching treatment. It's part of why I invited him to the conference. So great question. I hope the answer is satisfying. Yeah, give me 10 minutes. Medicare for all is the cry. And, the advantage, if we could do it, would be it would simply cover everyone. And there would not be the incentive to just kick the can down the road for 3 or 4 years until the person will be on another policy or they'll lose their job and they'll be on the public rolls in terms of the cost. But you know what is true about Medicare? The parity law does not apply to Medicare. Yeah, the parity law was in 2008 and Medicare was written in the 60s and 70s. And so if we could snap our fingers and make Medicare for all, oops, we lost parity. And it is true that, so what you're describing, your analyst has stopped, he's moved away from the Medicare system because he or she is finding out that I have to spend an hour interfacing with the computer and convincing them that this treatment is medically necessary. That is the kind of thing that is explicitly a parity violation. You cannot set up dollar limits. Whatever your heart surgery costs, we'll pay it, but you're limited to $50,000 lifetime for mental health. You can't do that under parity. A quantitative limit is not allowed. And you can't have non-quantitative limits. Hurdles like that, an hour for every couple of hours of treatment, you wouldn't be allowed to do that under parity. You can under Medicare. Medicare is not covered by parity. And until the class action lawsuits hold insurance companies' feet to the fire, you can do it anyway in spite of the parity law. So, but I think that tide is turning because of the top-down and bottom-up efforts. I'm really excited to see what implications this WIT versus United Behavioral Health remedy will have. We'll see, and there's it's not going to be nirvana in another year, but I'd love to see what impact. We're already seeing increased authorization for treatment for patients at Riggs. Yeah, well, that's a terrific question because it's the one I can answer in one word. No. Nobody. Look, part of the problem is the system we have, it's too one patient at a time or one group at a time. We really, to move the needle, we have to get to the people who don't even want treatment but are having terrible troubles and they're suffering. We need to get to the people who want treatment but don't have insurance. There are certainly countries that are doing better than we are in terms of having access to care. But how we're going to design a treatment system, and I don't have the answer, that somehow lets people engage things online, see if they can get better a bit, and then have a way of triaging so that by the time somebody gets to the analyst, it makes sense for them to be at the to get to the analyst, or how we're going to do that, I don't know, and no country has figured it out. However, Peter Fonagy, who's one of the speakers at our conference, has had a lot of influence in beginning to develop a system in the United Kingdom about this, and we're hoping to hear more about that at the conference in the fall. But I don't think, there are real workforce shortage issues. It's very hard to imagine how to provide everybody the service they need. How do you get care to people? And of course, I won't mention names, but locally, one of the things that's happened is a coalition between people from the Berkshire Hills School District who found we're running a hospital here. It's not a school. There are too many dysregulated kids. And finding that the referrals to the local mental health center just weren't working. The families didn't want to go. They didn't follow through. The calls back didn't happen. That what's been introduced is a model called collaborative care. So with, people will bring their kids to a pediatrician's office, but they won't maybe bring their kids to a mental health center. And so there's been a kind of a model project for using the link between the schools and the pediatrician's office, and having someone to coordinate the referrals and make sure they happen when they do go to the mental health system. That has made a huge difference in this county. And the interesting thing is that it's a really interesting thing to me that this led to such a dramatic shift in the reading levels of the kids in the school, that the school was designated as, making astonishing progress, one of two schools making astonishing progress in the county, and somehow the Berkshire Eagle doesn't pick it up. Yeah, no, it's such a serious problem, and we see the consequences. I don't know how many people are from the county and know this, but there were a series of suicides in recent weeks in the town of Lee, and fortunately, it's a happy story about what happened in terms of making a change in the school district around the collaborative care model, but to have that followed by a series of suicides and all that comes with that is it's a messy world. We're not very good at taking care of one another. One of the things Carol Gilligan writes about in her recent book is the problem of the way that the me that we each have has become separate from the we that we're all part of. So that we now think about it's either me or we. I want to take care of the me, not the we, rather than recognizing that the me is part of the we. and that, you know, we really have work to do about building communities. And what you're talking about involves a kind of community building and working together. And I can tell you one thing not to do is for me to say, hey, I have a long CV. I'm a smart psychiatrist. You should let me help you. That is the last way to get in the door. You have to go to learn. You have to go to inquire. And you have to build relationships. It's not going to happen by authority or blaming. We're going to have to find ways to build alliances and make it work. We do. We actually have family weekends. We have the families come and we try to help them talk to one another. But no, it's very important. And actually, I've at the National NAMI meeting a couple of years ago, I talked about some of this, not specifically the 4 freedoms, but the issues of what was being addressed in the lawsuits. It's very important to hold in mind this business of working top down and grassroots up. And NAMI is grassroots up. It influences the legislation, but it also educates and has an influence at the grassroots. National Alliance for Mental Illness. Well, there are people who don't feel they have a problem and that they need treatment. And, you know, look, you couldn't do it now because it's such a different world post 9/11. But one of the things one of the powerful memories I have was visiting Washington, D.C., right outside the White House in, must have been the 1970s or 80s. And there was a woman standing outside the gates of the White House wearing an aluminum foil huge hat, disheveled, carrying a picket sign that asked the president to stop bombarding her with cosmic rays. She was obviously a seriously disturbed woman. And I felt a combination of feelings when I saw this. I felt on the one hand, you know, oh, how awful, how kind of embarrassing, how awful for her to be sort of camped out in front of the White House day after day. On the other hand, I also felt, and it's my reaction, I'm not suggesting anyone else needs to share it, I also felt, well, this is America. This is freedom of speech. She is a sentinel of democracy. And you know, it's such a horrible balancing act about considering, when you force someone to have treatment, you may improve their symptoms and thwart their agency, their authority. And I think this is what a lot of the struggle is about. And so, you know, right now, there's someone we're working with at Riggs where we're in just this struggle. Can we wait while this person figures out that medications will make a difference? We're not going to force them. All we can say is, well, you know, we don't do that, so you couldn't be treated here unless you take the medications, and they'd probably leave. But, you know, how do you work that balance of how do you build the alliance in which the person says, I get it, this is worth my doing? I mean, it's a huge problem. There are millions of people who are in that area of maybe refusing treatment. These are not simple problems to solve, and they're not cheap. But I also don't want to throw away freedom as a central tenet of what we try to have people hold on to. Thank you.